Good evening, everybody. Thank you for joining us for our evening webinar presentation. My name is Joe Suka. I'm the Business Development Manager for Coltan Endodontics, Australia and New Zealand. I'd like to welcome Mehdi, our presenter for this evening. Tonight's webinar will be the last of our webinar series titled Current Concepts for Effective RCT Obturation. And I'll just go through some housekeeping rules. Firstly, all your CPD points will be emailed to you after the presentation. And secondly, if you've got any questions, please click the live Q&A button at the bottom of the screen and post your questions. Questions will be answered at the end of the presentation. And I'd like to now formally welcome our presenter for this evening, Dr. Mehdi Rahimi. And I'll just put a bit of a bio for Mehdi. Mehdi is an adjunct at the University at Orange and a professor at the University in Melbourne. Mehdi graduated with a University of New Zealand in 2002. Dentistry Endo degree from the University of Melbourne in 2008. Mehdi is also a professor at Melbourne University and a CPD mentor for the ADA New South Wales. Publications in the field of forensic dentistry. Mehdi, including the Sir Alan Wilkins Young Researchers Award from the International Association. And the Pierre Forsyth Academy Award of Merit. Mehdi is the branch Federal Counsellor of the Society of Odontology, New South Wales, and a Fellow of the International College, and a Fellow of the Pierre Forsyth Academy, and a member of the Royal Australian College of Dental Surgeons in Endodontics. New South Wales Federal Counsellor. Thank you, Mehdi. I'll hand the mic over to you.
Thank you very much for the kind introduction. Can everyone see my slide? Is that?
Yes.
Yeah, thank you. So just keep me posted if there's any issues, Joe. So it's an honor to be presenting tonight. I can't see you guys. I wish it was in person, but I suppose that's another way after hours to, while you're sitting comfortable at home, listen to someone give a presentation. So it's the new way, I guess, post-COVID. Anyone that wanted to ask questions post this particular presentation, feel free to email me, Mehdi at gentleendodontics, spelled this way, .com.au, and I'm happy to respond. And I'm also personal and, Gentle Endodontics. We've got Facebook and Instagram, so feel free to private message me if any part of these presentations don't make sense. I'd like to make just mention something before I go ahead with this presentation, that I'm a clinician and I love teaching. I have no vested interest in anything any product, anything that I'm about to talk to you guys about. I thank Coltan and Henry Schein for inviting me, and of course, they've always been generous with giving me products. I get special rates, but it doesn't necessarily mean that I'm just here to tell you guys what works for me. And again, no vested interest in anything. When we talk about obturation, often this topic is not covered in various congresses or various courses because they say it's the least important part of the entire treatment. We know in various papers in the past they've used sparrow droppings as root fillings and it seemed to work. We're talking bioactive, biocompatible materials. I'll mention a few today, but the world's first ever was in the 1960s and 70s where they were using sparrow droppings. Technically perfectly root filling, even though it looks good on two-dimensional, even three-dimensional views, it can still be infected because maybe the dentist during the procedure had leakage through a rubber dam or didn't use a rubber dam, so you can't see bacteria even if you're judging a radiograph. what about, the latest, greatest obturation technique or material? I mean, I'll touch on it today and tell you guys what I do, but, what is new? I'll cover some of the things that are new in this topic today. The term three-dimensionally obturating is the least favorite term that I've got. Herbert Schilder in the 60s and 70s used to cover warm vertical condensation, and part of that was filling the entire root canal system, as he called it. Three-dimensionally, you can't even clean the root canal system thoroughly, let alone fill it. So you can't completely ever obturate the root canal system. It's a lot more complicated than that. Hardly ever would with previous presentations, or as you'd ever be able to clean the entire root canal. Most of what we do probably still leaves about 30-40% of the root canal system untouched. So it's often, we mention endodontic therapy, and it's quite basic. If you're able to disrupt the biofilm, you're never going to get rid of all of the biofilm. It's this sticky, adherent, complex microorganism, they interplay with each other, microorganisms, if you like, and they're sticking into areas where they're very difficult to reach or disrupt. But if you're able to, with your disinfection, disrupt the biofilm, then you're able to get healing. So your irrigant, after you've instrumented to the right area of the root canal system, is able to get to that apical third area where most of the canal ramifications, the apical deltas and lateral canals and all the biofilm is. So once you disrupt it and you're able to get your irrigant there, and irrigant delivery systems, agitating irrigants, using systems which are able to give you that acoustic streaming effect, you're able to then reduce the bacteria somewhat more below a threshold that causes disease. And at the same token, you're using sometimes medicaments to, for example, fill that space, have a bit more antibacterial effect, and then watch the case over a period of time until you see, evidence of, the lesion healing, which will be a good sign for obturation, which is, I think, this is what we mainly do in endodontics. I mean, occasionally we do a single visit treatment, especially the specialist who is more experienced in performing all the procedures, but most often the general dentist will be doing it in multi-visit to make sure there's healing, to make sure patients are asymptomatic. So it's good patient management prior to obturation. I wanted to touch on patency because I'm not sure if in the previous presentations anyone ever stressed it, but I really do stress the fact that it is important. I mean, that apical zone is quite complicated, but at the very least, through the path of, let's say, the most common path, the path of least resistance, let's say if it's here, or maybe the file would get here, what you're trying to do is get your files to exit through that portal of exit and create a patent canal, so therefore your irrigant can get to the area to disrupt the biofilm and reduce the bacterial load. So what's often seen in the literature is if you don't have patency and you've got a lesion, then your success rate drops. As soon as you get a patent canal, no-brainer, you're able to get the irrigant there, you're able to reduce bacteria, and your success rate increases. So then once you've done the preparation, obturation is a good function of chemomechanical disinfection. So it essentially tells you how well you've prepared the root canal system. For example, in this case here, we know there's been, a very poorly done previous endodontic therapy. It's quite voidy. It's a bit short here. We also know that the obturation here shows that the second canal is found, probably why this lesion is healed over a period of time. And in order for us to stop this process from reinfecting, we need to have good coronal seal, which is a topic for another day. But coronal seal together with root filling seal prevents reinfection as well. So that's another reason why we obturate root canals. And again, I touched on the fact that you're not going to find a squeaky clean root canal system. You're not going to be able to clean everything perfectly. And the question is, why is it? What happens? Why does the pain from the patient go away? The symptoms resolve, the draining sinus heals, or the lesion starts to heal. So again, the thing is, a lot of dentists sometimes say, what did you do differently? Why did this work when it wasn't working under my hands? And I tell dentists, look, I didn't do anything differently. I just stuck to the basics, did the basics right, had a good riboderm isolation, had good access into the root canals, was able to establish patency and then agitate irrigants. And all I did probably is I left bacteria behind, but I left less bacteria than you. That's why it healed. So it's all about reduction of bacteria below a threshold that causes disease. And in almost 95% of cases, things will heal and go smooth. And in terms of obturation, if we're looking at what else is the obturation material doing, this thing called entombment or imprisonment, like suffocating the microorganisms that remain within the root canal system of oxygen. They can't, there's no space for them to grow. They can't in synergy work with other bacteria that are there to create another infection. So that's what the obturation is doing. It's sort of, there is indirect evidence in the literature that you can look at where when the canals are prepared closer to the apical zone, not only you've addressed the apical third, say you've established patency, but you also, in many of those cases, there's still bacteria, but the bacteria is below threshold causing disease, and the remaining bacteria are suffocated. They can't gain access to potential for regrowth. And what about the gutta-perca material? Gutta-perca in the past was impregnated with metronidazole and antibiotics. Then we have the scare of antibiotic resistance and hypersensitivity reactions. And then we obviously got rid of any antibacterial component, but we know that gutta-perca is bacteriostatic. Other products have come on the market that actually encourage bacterial growth. One in particular is Resolon. There's papers on that, but that got discontinued. So no longer, I think, to my knowledge, anyone is using Resolon, or it's not being sold in Australasia at least anyway. And the filling is acting in terms of seal together with the restoration that's hopefully not defective or leaking. What the filling is doing is it's trying to block access for percolation of bacteria back into the root canal system. Now, we know that the outcome studies, which is the highest level of evidence, and we're talking, a lot of what I'm talking about today is evidence-based. A little bit is sort of less evidence-based, but I'm trying to stick to the evidence we have. So what we see from the literature, in particular the Burns paper, which looked at lots of publications and systematically reviewed publications from 2003 to 2020. What they found is something we already know from many other outcome studies, such as the Ing papers, that the well-compacted root filling, absence of voids, results in better outcome. Absence of coronal seal, so cases where you got caries or defective restorations or loss of restoration result in worse outcome. And we know that also another thing that affects outcome is lesions. So if there is a lesion present at the time of the treatment, those cases seem to have a slightly poorer outcome than when you don't deal with an obvious lesion radiographically. And some of those studies have been done three-dimensionally. So we're talking CBCT analysis, which is more accurate at picking up lesions that are harder to pick up on 2D. So with that in mind, I'll show you a slide. And the point I'm trying to make from this slide is if I was going to cover every technique and every material on obturation, I'll be here till next week this time, and I'd rather be with the alligators. I've got to get home to my kids, and I'm sure you guys don't have all the time for that. So what I'm trying to show you is, as with many things in dentistry, it's manufacturer driven. Sometimes a manufacturer comes or a rep comes and tells you this is the new product and it does this, and endodontist Mehdi Rahimi uses this, or another endodontist that works with you guys or near you guys uses it and swears by it. The reality is that what you got to understand is as you get better and as you're a clinician, you've been around for long enough, lots of things are going to get sold to you. And sometimes you got so many things in the clinic, you don't know what you've used and what you haven't used, and you forget what you have. So the reality is that, there is a lot on the market. In terms of obturation techniques and materials, the level of evidence is lower generally, but it doesn't mean that, just because there's a lot on the market, some things that we mention are not going to make your life easier. So I'm a very practical clinician, so I'm going to keep it as practical as I can and give you as many clinical tips along the way, but some things have made my life easier. So the things that you see in front of you, including the GottaFlow BioSeal, which I've been using in the past few months or maybe around about a year, I really like the consistency of this particular sealer. So I'll cover this. This is a bioceramic. I do like the B&L. I like it because sometimes in some teeth with, say, limited mouth opening and upper sevens, say, mesial roots, it's very easy to maneuver in. It's a very light object, I guess. And the thing that I guess is negative about it, I'll tell you straight away, having a cartridge is more expensive, but a cartridge means easier for your nurse to clean it. And it's less likely this area here, it clogs, and eventually this area starts to play up and fracture because people don't clean it well and they forcefully try to inject GP with it. But these are the most common things I use. Now I keep changing gutta-perca depending on my prep, but I like the Conform Fit, Precise Fit gutta-perca, which makes my life easier. I'll mention that too. And what I'm showing you here, that if you use cold, obturation techniques or even warm, you see a bit of a pattern. And the pattern is trying to make your life easier so you don't have to do step back or lateral consultation with lots of accessories. You're trying to machine the root canal system with preps. You're trying to obturate the root canal system predictably with materials that don't leak or are less likely to leak, materials that are bioactive today. And you can even use a single cone that fits your prep really well. And that's where the technology is going. If I gave this lecture 5 years ago, I would never, ever talk about single cone. I'll be bagging single cone out and saying those endodontists that teach you that, they have no idea what they're talking about. And, I disagree with it fully. But today, I've changed my view on it. And that's what this lecture is about, why I changed my view on it and my reasons or justification towards that. I really like the Elements IC. So again, BLL unit and Elements IC is the prominent things I have in my clinic. If you ever visit any of my clinics in Sydney, Parramatta, Chatswood and Double Bay, you'll see it's exactly what I told you. So I'm not telling you fibs. I'm not making this up. We have established positions. So most of what you read in the literature tells you, and most endodontists agree on this topic of increase your stable gutta-perca component as you obturate those root canal systems, which are predominantly irregular at times. So especially coronally, most root canal systems are a bit more irregular. They might be ribbon or oval shaped, and there might be isthmuses there where you can fill better with more maximizing gutta-perca. Whether it's warm or cold, different story. But what you want to do is increase your gutta-perca and reduce your sealer because the sealer is the weak link. Doesn't matter what sealer you use. Many of the sealers on the market shrink, okay? And what happens is when you place your sealer, you can end up with voids and sealers break down over time. Better to have thin film of sealer than thick film to maximize your gutta-perca, and sealers work better in thin films like resin composites, which shrink if you do them incrementally, or in thin thicknesses, they work better. So all of what I tell you, I've studied, I guess, I know that this back to front because that was my DCD in endodontic, my doctorate in clinical dentistry thesis when I went through the postgrad training program. And we know that when you subject under load, like you're grinding, you're clenching, you're chewing, those forces end up putting concentrations of stresses around the cervical and eventually down to the middle of the root, and the sealer can break down over time. So like any post cement, whatever cement you use, whether it's Real-IX or Maxim cement or whatever you've got on the market, over a period of time, we know that that's where the breakdown occurs. So it can be load, it can also be matrix metalloproteases that can develop over that film where the bond is, and you can lose your bond. So once again, what remains is that gutta-perca you see here, which is very stable. Now, the gold standard sealer, especially if you guys have been through dental school, most of you will be using AH+, previously known as AH26, the older version. Why is it that that's the gold standard sealer? It's an epoxy resin sealer. It's a resin. The reason for it is because whenever you studied this sealer and you compared it to a new sealer or an old sealer, it seemed to not perform any worse. It was either mostly equal or better in terms of microleakage studies and bond studies. And a lot of the studies that I did, I was on bond studies, but I also know as I did those studies, there's a lot of variation. And even when you do the tests multiple times, you can get a bit of differences. So they're not very accurate, perfect studies. And the methodology often in these studies is not perfect either. And that's why, for example, some journals such as the Journal of Endodontics doesn't accept leakage studies, and the International Endodontic Journal, for example, accepts leakage studies, but very stringent criteria. They don't generally accept those studies because they're weaker studies. In terms of AH26, I like the thickness of it. I like how it's able to coat the gutta perca better. It's a bit more viscous compared to AH Plus, where it's a bit more runny, and depending on the room temperature and which part of the syringe you get, especially if you use the jet, it can be quite runny at times. So people liked AH26, therefore, things such as the silver-free AH26 that doesn't discolor teeth, similarly to, doesn't have silver highlight AH Plus. Now we've got AH26 silver-free and a few other sealers that are similar, which don't discolor teeth, came on the market. So then, that was one other worry that was put aside. The AH Plus doesn't expand or shrink much, so it's very stable over time and doesn't solubilize easily when it's in contact with moisture. But again, if you compare AH Plus, AH26, the gold standard, to, for example, the Gutta Flow BioSeal, which is a bioactive material. Again, no vested interest. I mentioned this. This particular material doesn't expand or shrink. It's very, very stable. So it's very, very. Actually, when there's moisture, it sets. It's hydrophilic material, so it's able to set with moisture like MTA, the original MTA or calcium silicates. So it brings me on to why MTA-like materials, these calcium silicates that have been, they're on the market and they're here to stay. They're not going anywhere. And the more I give this lecture, the more I've got to mention more brands that come out. Why is it revolutionizing the way we obturate root canals? It's because it's challenging convention. Now you can pretty much, if you have a certain size, apical size, and under my hands, anything above a size 50, I definitely use MTA, but I'm able to even obturate with MTA, traditional MTA, which is harder to compact, and it's not like the sealers that we have that are calcium silicate sealers, but I can use traditional MTA. This is ProRoot or MTA Angelus, as long as I've got about a size 30, 35 apical size. So I've learned techniques that's able to do that quite predictably. But most often where I revert to it is when I've got a size 50 or larger. Why? Because with those open apices, there's more chances there's moisture, there's more chances fluid flows in. And that fluid, if it's not bacteria, it's still going to disrupt the setting reaction for any other type of resin-based sealer. So this this calcium silicate biocompatible material can set with moisture like the Portland cement used to. Portland cement is the basic how my uncle Memo Torabinishad, distant family member of mine, came up with this. Notice MT, Memo Torabinishad, and his wife Ashi. You've always got to make sure your wife is happy, happy life, happy wife. So that's why Ashi's name's there too. And if you extrude with this material, it's biocompatible, so there's no reaction from the body. You can put it under your skin. It won't react. These tests have been done on rats and many. It's the most studied material, actually, in endodontics. That I'm like. It's almost like there's two materials that are really well studied: titanium in implants and calcium silicates, especially MTA, in endodontics and dentistry. And so we know that when you put MTA in cases where you do surgery, normal looking cementum grows over the top. So you get normal periodontal ligament growing over the top of it. That's how biocompatible it is. If you do a pulpotomy, for example, and as long as you remove bacteria, the pulp, obviously being very resilient, recovers. And in those cases where you've done vital pulp therapy, normal looking dentine grows over top of MTA. So you don't have these tunnel defects or these areas of leakage like you might get with Lenamix cements or calcium hydroxide based cements that we used to use like Dical. One of the problems with MTA, not only its handling properties, but another problem with it is the original MTA would discolor teeth over time. So it's not a good idea to use it in anterior teeth or anywhere where it's in the smile line. And some patients will be upset even if the lower 7, which they never show, would have looks dark. They get worried or get upset. So that's why these days when you look at the new improved MTA, one of them, of course, being the biodentine-like materials, but the other one being the traditional MTA that's been they've changed it. It's got bismuth oxide, which doesn't discolor teeth. That brings me on to the new sealer and obturation concept that's been around. It's not new anymore. It's been around since from my knowledge, 2015-16 onwards, where the papers came out, where people are talking about biodentine or bioceramics, and often the BC putty is like a putty style thing that we use, or the biodentine is a putty style, where they're talking about picking it up on a flat plastic or a Hollenbach, and you're able to sort of take it and place it where you need to, much easier than handling properties of MTA. When you look at cost, to be honest with you guys, the cost is not too different to MTA. They're much of a muchness. So in terms of if it's going to be cheaper, it's not cheaper. However, it's much easier to handle. And in terms of retrievability or retreatment, it's easier to retreat as well. So I think the only thing that I don't agree with this slide is the lower cost than MTA. It's sort of, now that I checked last, not too different cost-wise. What about when you use it in MTA pulpotomies? Because when you do pulpotomy, that's where you really look at the histopathology of it. That's where you really look at the result, the biology of it. It seems to be very similar to MTA. So we get very good results with pulpotomies as long as the cases are selected carefully and the procedures done carefully. And it's a very similar type of morphology when you look at it in terms of its structural integrity when you look at biodentine or any other bioceramic. And this is what I use in the clinics. It's called Gutter Flow BioSeal. So it's got increments within the sealer of gutta perca, but also within that, together with its calcium silicate based material, it doesn't discolor teeth. It's got the barium sulfate. It's got bioactive glass. The zirconia doesn't discolor teeth either. It's definitely certainly improved in terms of over the years. The BioSeal 2, for example, is the more improved version that I've been using in the clinics. Why I use it is it doesn't expand or shrink. So it's in fact, it's able to seal to expand slightly than shrink. So it's a kind of a good thing. So you're not going to have gaps like resin composites do, and many other products that we use are resin composite-based materials or epoxy resin. And they don't discolor the tooth. That's the other reason why I use it. The concept and why it's changed. People are doing more single cone. Even if you think you're doing lateral condensation, you're probably adding a few accessories which you might heat out and might not even be effective. The reason why in endodontics I've reverted to single cone predominantly, I mean, I still do hybrid warm vertical, but I realized I'm injecting Lex GP, is because, my access became smaller over time, and I really focus on access because I know I want to preserve as much tooth structure, especially pericervical dentine. So the world of endo has changed. You don't need straight line access with today's files, such as for example, the HiFlex OGSF or other files that have been heavily heat treated, because you can pre-curve them, you can get them into areas which are difficult to reach. Now, I don't recommend this for the amateur dentist or the dentist who's probably not experienced enough, but over time, you'll be able to have tinier accesses. I don't like calling them ninja, but I call them conservative accesses. And sometimes in certain situations, if you've got a very thick truss, you leave the truss behind because engineering-wise, you're keeping the strength as much as you can of that tooth. You're trying to minimize and be more minimally invasive in what you're doing to preserve as much tooth structure in the critical area, which is the cervical area of the tooth. Together with the right restoration, you're able to prolong the lifespan of that tooth. So because of these tiny holes, your pluggers are not going to fit. Your heat source, whatever you're using to heat out, the element is not going to fit exactly or go beyond the coronal third. Doesn't matter how good you are, you're not going to be able to go any further apical unless you really open and weaken the tooth. So a lot of the preps are very conservative and they're effectively single cone. And the materials we use these days, we want them to be hydrophilic. So if there's any moisture, they set with moisture, apically especially. And there's moisture everywhere in the root canal. It's never, ever dry. Even when you use a paper point, there's still moisture. And you want to make sure they don't leak. And you want to make sure they don't change shape over a period of time. They remain dimensionally stable. So we know that then there's papers, quite early, 2022 and onwards, where Gutta-Flow BioSeal had a significant better sealing ability than AH+. So the gold standard AH+, and now there are papers to suggest that calcium silicate-based bioceramics are superior. They have, I suppose, they are the future, if you like. And another paper here is an example where single core obturation resulted in good obturation. So when people assess obturation, William Ha, and Dr. Mortamedi, they looked at obturation. The Iglesias paper, very good at picking up where the voids are. When we assess obturation, two-dimensionally at least, the voids seem to be coronal. That's where the irregular part of the root is. But middle to apical zone often, it's more uniform with your prep. Your cone fits well as long as it's rotary and conform fit, if you like, or precision made cones, which I'll talk about. Then you're not going to have many spaces and you're not going to have many voids. So for that matter, the coronal part, those 2, 3, 4 millimeters of the cervical, I inject GPN. And sometimes if you've got wider root canals, if you've got resorptive defects in the middle of the root or coronal, you might be able to then do backfill with heated gutta perca. So we mix heated gutta perca with cold single cone apically, and often most of the root canal system, all the way to the coronal third, might be single cone in the very fine preps. So calcium silicate materials. What we know in terms of the literature, this is a comprehensive review. It's not too old, it's 2020. Lowest micro leakage out of all the sealers we looked at, most favorable antibacterial effect, excellent biocompatibility. The problem with these materials is because they are good, everybody is coming up with a calcium silicate based one. And some of them use MTA, like Neo MTA Fill Apex, as a buzzword because they know endodontists use MTA commonly in many, many procedures, perforation repairs, open apices, and many other procedures, irregular roots. Even when I just had a dentist today where they had a cracked tooth, and when I told them they're going to lose the tooth, they started crying. They didn't want to lose the tooth, and I'm trying to save it, but it's got a crack that's very borderline. So we know that there's some case reports now where if you use calcium silicate such as MTA in the coronal third of the tooth, if you pack it, it's less likely for that crack to leak, and it's less likely you delay the loss of that tooth. Eventual loss will happen, but that's what we did today. I was packing MTA at the coronal third of the root, just pro-root MTA or traditional MTA. So there's a lot on the market. And the problem with a lot on the market is that, there's a little bit of concern. And there were some papers in late 2019-20, particularly by David's group, David Donomer, where, we had issues such as, they're looking at these materials and the compositions are different. The amount of, if you like, calcium silicate or MTA type products within the product is less. It might be 10%, whereas it's mixed with a lot of other stuff like wax and other materials. And there's a concern with it being slightly soluble. So it's bioactive. It's great. It releases hydroxyl ions, this material, as it's setting. So it creates an alkaline high pH environment. So it's antibacterial, almost like releasing calcium hydroxide. Okay. But the problem is if it's bioactive, when is it going to stop being bioactive? And there are some papers, again, predominantly by one group, but a few other groups as well, like this group, Dr. Silva and Fidalgo. I'm sorry about the language. AH Plus presented lower solubility than BioC, CLR, BioRoot, and MTA Filapex and other bioceramics. So it's starting to question whether when we use this material, is it possible that long term the material dissolutes away with time and we end up with reintroduction of bacteria, regrowth and reinfection. So, the verdict is out. I'm giving you guys as balanced and evidence-based because I'm obviously, I assess the evidence. I'm a clinician, but also a researcher as well. And I'm giving you as evidence-based as possible that I don't know the answer, but it is possible that the material can dissolute or become too bioactive over time. And then people need to look into creating materials that are less bioactive. The other thing about the material which people were worried about, and it's proven, again, with Donna Meier's group, effectively, retreatment is not an issue because people were worried if you put MTA in root canals, you can't retreat it. Yes, if you put traditional MTA, yes, but if you use these materials, they are retreatable. And in fact, they might be easier to retreat than AH+. So the effect of weakening teeth or laterally transporting teeth or perforating during retreatment is less with these materials. So systematic review, one of the best. My uncle Turbinijad recommended I share this with you guys. A meta-analysis of the literature. It's quite recent, sort of middle 2022 publication. They found that MTA is the number one choice when we talk about obturation of any part of the root canal. In this particular case was endodontic surgery. However, even with root fillings, we use MTA. It seems to be closely followed by bioceramics. So bioceramics are the second choice, but I can tell you with the advents, the more we wait, the more they become streamlined and they will overtake MTA. So this is why I'm using BioSeal, because I know it's a stable bioactive. It's less likely, or they're working on it to become less dissolute away with time. And it's still it's not going to stay in teeth, and it's very stable. It doesn't leak. It's quite a good material. Finally, in the last part of my presentation, I want to just mention a little bit about the technical aspects of endodontic obturation. So we know that the shortcomings are when you deal with very weak teeth, like low incisors, for example, are quite weak. It doesn't take much lateral condensation or spreader force as you put your spreader deep into that root to cause cracks. So the load to fracture is quite low in some weak teeth or slender teeth, such as low incisors. So the literature tells us that, in the past we used to do lateral condensation, and the problem with lateral condensation, you'll get this hedgehog effect, but then if you add accessory, it doesn't mean that you've done a better obturation. You probably heat away most of them when you come to heat it out, and not many of them actually are effective, and you end up with voids. So there are a lot of voids when you add accessories. The good thing about lateral condensation is that you're able to control your length. So at any moment, if you think you need to add more accessories, you can. You can control density. And also, if you get it wrong and something slips through, you're able to go back and pull it out and start over again. Of course, you're going to use a rubber dam. You're not going to do what this prosthodontist did. He believed in endoing every tooth, even if it's vital, so that just in case it becomes non-vital, about 1 in 10 become non-vital after crowning, depending on the case, 1 or 2 out of 10. It doesn't mean you should endo all, definitely not without a rubber dam. So apically, we know that we want thin film of sealer. You have it. If you machine the root canal and use a match taper GP, especially conform or precision made GP, it's less likely you'll end up with any voids. It is the coronal third where you got to heat away that GP and inject it with warm vertical. What are some of the drawbacks? What do people, talk about in the literature? A lot of the cases where you may have seen cracks in the past, even anecdotal amongst the older endodontists, is cases where they used to prepare the root canal very wide up the top. So not preserve pericervical dentine, have 10, 12, 15, 14 tapers, quite wide tapers. Keep the apical zone quite narrow, so you're able to compact the GP apically to coronally, like, thin increments of GP, and you had thick pluggers which will go really deep and cause crackle fractures. So some of the drawbacks of traditional warm vertical condensation were that. And what are the benefits? Of course, you got very good flow and you're able to entomb more of the root canal system, so you reduce that potential for reinfection. So that's one of the great things about warm vertical. You're able to fill the irregular parts of the root canal better. Let me show you an irregular canal where you didn't know. I mean, Mark Johnson here, courtesy of him, I thank him always in my lectures, a great endodontist in Melbourne that used to work with me in Sydney, Melbourne trained like myself. And he has a lot of good cases. This is an example perfect example, when he's done his, working length determination, when he's done his endodontic preparation and finished it and puts his cones in, he can't see anything. But when he comes to obturate with warm vertical, he notices there's been some bacterial in origin inflammatory internal resorption. So as you can see, even under the microscope, this is quite bottleneck. It looks just like a narrow orifice. In the middle of the root, you can't sometimes see this irregular anatomy. So why I like hybrid warm vertical condensation is because I'm able to now fill this area with warm GP, which fills the confines of the root canal much better. So if you were doing cold lateral, you'd be adding a lot of accessories, and those accessories will be everywhere. And when you heat it out, you will end up with a very voidy, I can guarantee you, root filling. Doesn't matter how many accessories you add, you're not going to get them perfectly. Injectable GP is the only way. So let me show you another case where it's a case of mine I show in many of my lectures on obturation, because I do this lecture a lot. And you can see the lower 6 and the lower 7. The story is the dentist, being a prosthodontist, never took a radiograph, unfortunately. Maybe had an OPG somewhere, an old OPG. They came to do an inlay in the lower 7 and something flies out of the tooth, being a silver point. Then they decide to refer the case to me for a second opinion. And of course, I see lesions that are asymptomatic. But after he touches this tooth became symptomatic. The 6 was very tender to percuss, and patient ended up with a flare-up or swelling. So in the process, what I'm trying to show you is how we did this hybrid warm vertical condensation. So it didn't have 3 canals, the lower 6. It had 5 canals. And what I'm trying to show is very thin GP points, very narrow tapered, very conservative preps. And I'm talking about the middle of the root to coronal, where even when my axis was smaller, I probably heat out a bit less, and I'm able to then backfill. And I also want you to pay attention to the distal root of this lower 7, where the single silver point flew out. You needed to add many silver points. It was wide. And in terms of obturation, you need to add a lot of accessories. So this is why heating out to mid-root and then backfilling with GP, you're able to more predictably fill the irregular parts or the wider parts of the root canal. I want to mention the Conform GP perfect fit cones. The Roica Gutta-Percha points, they are perfectly designed. They're no longer hand rolled. There is a few others on the market, such as the Rotate GP points, such as the True Anatomy GP points, where they also fit perfect, and the Zen Flex GP points. So what happens is in a manufacturing, what we're doing now, we're not hand precise, machine prepared, and they are checked with 3D laser verification, and they're kept in a very safe and cool environment. And when you receive those GP points, guarantee you that if not 10 out of 10, 9 out of 10 of them will fit perfectly to length, unless you didn't prepare the canal well with your instruments. So this means that it gets rid of the problem of your cones not fitting, such as the old systems. As examples, twisted files, pro-tapers and pro-taper necks and whatever, those GP points never fitted perfectly. I'm sure you know what I'm talking about if you've ever done endo long enough, because the older systems, the GP points sometimes will be short or just didn't fit perfect, and you're wondering what you did with your prep. You did the prep right, but your GP points weren't perfect fit. Why do I use in the clinics the HyFlex EDM, in particular the new system, the OGSF, the orifice shapers, together with the glide path file, which is again the HyFlex electric discharge treatment has been done on it, and the shaping file and the finishing file. One of the reasons why I recommend is it gives you a holistic system, so you've got the whole system. And I don't believe in, let's say, the reciproc-like files, the single wave one files, because I don't believe if you do endo enough, one file system does all. Okay, so I still think one file system's ballooning out the prep, or it's enlarging the prep, and you're ending up with bigger tapers and you're pushing debris laterally. So that's my opinion, and I can prove the literature if you challenge me. So what I like is, because of this heat treatment together with the electric discharge treatment, the files have less faults, and they are very good at following S-bends and curves. They have very good conform fit. So they have excellent, flexible, strong files. And because they're highly flexible, they can get around very difficult areas. And also that you can bend them, they keep their shape in the limited mouth opening areas. So you can pre-curve them and get them to very difficult to reach areas of the mouth. So the OGSF is what I recommend as an endodontist. Any of the HyFlex systems, what we teach the postgrads and the undergrads with at Sydney Uni. So at the moment we're using purely HyFlex, and I'm hoping the OGSF is, manufactured while it gets there and it's out in the market. So I really believe in what I teach. So I've been using it for a while now. I had the privilege of Joe Sukar giving me the files, and I've got some cases to show you with that. A very narrow coronal taper, preserves pericervical denting, and I like the variable cross-section. And the reason why I like it is because it reduces risk of fracture, and you're able to be more efficient at cutting as well. At different areas of the root, it will have different tapers, so therefore it addresses the root canal system better as you go through the sequence. So I want to show you this, which I show you in many of my lectures. And if you want to watch this similar sort of presentation, just type my name and you'll see a presentation where we did with Peter Norton. It was for, I think, Kerr or Henry Schein TV and previously. So we talk about this whole thing about, in the old days, we had the austenite phase files, and today we've got the martensitic files. They're more heat treated, they're more flexible. However, they're less efficient. So what I do is I hybridize a file that's a little bit less heat treated somewhere here, and I move on to the very heat treated when I'm dealing with really the finishing files or the real curves, so I can keep the shape of the root canal system. I'm able to predictably get to length without straightening canals or without elbow effect, if you like, when we used to use a lot of the old systems. We think we got to length, but we actually didn't get to where we want to. We didn't address the apical zone very well. So with the less heat treated, we can remove dentine quicker coronally, and it can break through calcification. And I actually found the orifice shaper here, which is a size 18 at the tip with an 11 taper, is actually quite a nice way to break through MB2 canals and calcifications. And it's able to pick the top of the root canal and flare it well. Very efficiently, you can get to, you can open it up so you can then get your glide path files to length, and you can get your hand and rotary to length. So I often use an orifice shaper before even I go ahead and use my 8-6-10 or 6-8-10s to length, back and forth to length. Okay, and then I don't want to bore you with this, but HyFlex EDM, definitely number of cycles to failure increases tremendously when compared to the original HyFlex or other files such as ProTape and twisted files. So let me show you how I use HyFlex in the past CM, but then now, of course, the OGSF EDM is what I use, and in the clinics with postgrads, we use a mix of HyFlex CM and HyFlex EDM. So first of all, like any canal, I always, with liquid, with moisture, and in this case, I made sure there's moisture. I scout the canal with either a C pilot, a H, or K. And I want to get to minimum about a 10 I don't like going to a 15 or 20 because it'll straighten the apical anatomy. So 6, 8, maximum 10, so you can verify with a working length film, or you can use an APIS looker to make sure you're patent before you use your other files. And so we're basically using a glide path file. So this is a glide path. It's about a 15 at the tip, and you can see how it nicely gets into the length. So this is a 2004 HyFlex CM, and what you see there is with a couple of very gentle strokes, you sort of kiss the tip and come back, and you probably spend 1 or 2 times at the tip and come back. And we're talking about a gentle, loving kiss, no French kissing, no leaving your file in one spot, because even these files, if you leave in one spot under stress, they can fracture after some time. They fracture a lot less frequently, but they can fracture. So austenite phase, it doesn't keep its shape. You can't pre-bend them. It can straighten canals. It's like a screw if you get it to length. That's why a lot of times, if you're trying to, in a long route, trying to get to length, you end up removing too much of the cervical dentine. So I don't recommend them for the entire prep, but I don't mind using a more or less heat-treated file, let's say austenite phase or something between austenite and martensitic, to just prepare the coronal part of the root canal so I can get other files in. So what I like about martensite files is that it keeps its shape. So you can get in through curvatures and it keeps its shape, and you're able to, prepare the root canal to exactly accurately to the apical zone. You don't elbow or transport the root canal. This is an example of the HyFlex OGSF, and it's the shaper file before the finishing file. And what you see there in a limited mouth opening, I'm able to get in, and it bends its way in. And my axis is a lot smaller in that mesial area. I left a bit of pulp roof behind, and I can pre-bend and get it in. I love that feature. I can get it in limited mouth opening. I can get it around areas where I've left a bit of pulp horn here or there to keep my pericervical dentine. So I love that feature. Here's an example of the finishing file in the same case. This is the finishing HyFlex OGSF. And what you see there is it's able to get into the area where it's harder to get into. And it's able to, again, very predictably get you to length. You couldn't do this with the traditional austenite phase files. And then when we talk about conform GP, this is actually a Roco 4% taper 25. And as soon as you prepare it to a 2504, a HyFlex CM or EDM, or you can see the cone fits perfectly to length every time, as long as you did your prep right. Before we had conform GP, when we had a prep size of a 35, for example, here, it never went to length. And here is a case where we used a true anatomy, 25, and true anatomy gets to length, just like the Row Eco GP point or other GP points. They are now, thank goodness for the conform fit, precise fit GP points. A little bit more on the practical aspects. I want to show you a quick demo video before I finish, or a couple more practical points. So often you would have an Elements IC in the clinic, and I do like the Elements IC. I give a plug because I think it's the Rolls Royce of all the obturation units. They've really refined the charger. It keeps more charge. It's easy to put it in and take it out, like the iPhone chargers, and it's got a lot of features that I really like. The cartridge I really like because it's copper coated and you can pre-bend and bend. So a little bit on practical. I dry canals after I prep them. These are the steps I take. I always measure my Buchanan pluggers. These days we have a lot smaller Buchanan pluggers for the more conservative preps, where you're doing single cone, but you want to just fill the 2-3 millimeters of the root canal. So often in the past, my plugger would fit about 5 to 7 millimeters for working length, but these days with minimal conservative preps, those preps meant that I'm maybe 2-3 millimeters within the root canal orifice. I may not get to 5 to 7 millimeters from working length ever, unless the canal's quite wide naturally. And I put a rubber stopper because I want to make sure the plugger doesn't go any deeper to stress the root, or sometimes in really wide roots, open roots, you might end up going through the root, and that's just a no-brainer. You want to put rubber stopper on your plugger. You dry the canals. When I take my cone fit, I'm always taking advantage of passive agitation of the irrigant, and I'm always using a moist environment to push my cones in. But the final thing is I dry the GP and I put a bit of sealer on my cone, and I might take another check film if I'm worried about being to length. But often I crimp the GP so that I don't need to take a check film. If my crimp meets where I am at the exact working length, and then I don't need to really take a working length. I know with a thin film of sealer, I'm in length. So I use BioSeal, and I put a thin film of that, and I place that in a couple of times. One of the things about putting your cone in a dry field, make sure you push it hard, because sometimes with this system, depending on the cone could be quite soft, the apex could be quite wider than you think, or resorbed. There might be resorption that you don't see two-dimensionally. You put your cone in, and if you don't push hard, as soon as you put your plugger over it to pack it a bit, it could slip through, and then it's very hard to remove, like this case, courtesy of Dr. Jeff Young, who was the treating endodontist to recover from this case when the dentist sent it, and then he cross-referred to me because I was the one who recommends this system. So I was told to retreat it. When we use the heat sources, we sear off at the orifice, and then we plunge into the root canal, and we call it a separation burst. And I'll just show you very quickly on the video. We don't want to bury pluggers because they cause voids. So one of the voids you see, apart from coronal voids sometimes, is middle of the root or wherever you've heated out the cold versus the warm, because you've buried your pluggers, the sharp pluggers, and you've got little voids there. And you want to make sure you inject slowly. Again, I really like the Elements IC injectable GP, and I really like the copper coated because after you bleed, you can extrude it. It's very thin at the tip, about a 27 gauge, and you can inject it slowly and just gradually fill. So I just want to finish off with a quick video clip. One of the issues we used to have with the original gutta-perca points is that, for example, you might have a gutta-perca point that's 25 at the tip, but then because it's hand rolled and not injection molded or precision made, it could be a 21 or a 30 or somewhere around between those figures. So it wasn't accurate, and it causes a lot of issues with the operator trying to get it to length, and it wouldn't go to the preparation length. So therefore, one of the advantages of using a precision made or injection molded gutta-perca like this 3504 Zenflex gutta-perca, it matches the preparation accurately, and almost every time, once you want to put it to length, it goes to length. And the other thing, if you notice, is the amount of flare. So you can see how slim that is compared to the wider tapered older versions of making or preparing root canal systems. So you're able to go to slightly larger apical sizes, which still, even today, despite the irrigant agitation delivery systems and them giving us advantages of, for example, being able to finish to a 25, sometimes in some canals you need to go to a 35, or in retreatment cases you might need to go to 35 or larger. And what you want is a larger apical size, but you don't want a terribly larger taper. So I'm going to measure up the 3504 Zenflex gutta-perca, and then I pick up a small amount of sealer. In this case, it's an epoxy resin sealer. And so I use a very thin amount of sealer because sealer is the weak link. And I place the sealer in 2 increments into very, very thin amount. And I make sure I've got good tug back. And we can even test the tug back by pushing out and pushing hard. The other thing about this particular system, because I'm doing a hybrid warm vertical compaction, is if I push hard, it doesn't slip through. So I make sure I push hard, and I make sure the gutta-perca doesn't slip through the apical zone or the foramen. So here we've got the Elements IC unit, we've got the down pack, and we've got the backfill. Advantages of the whole system is that traditionally, for example, the Elements 3,
it's very difficult to place the units back into the charger. It'll have to clip in. This is a nice, easy place back in type of friendly thing where it charges. It also keeps it charged for a lot longer, so I like that about the system. It's got a very nice screen. The cartridge, one of the advantages of the cartridge is that it is very easy to take out and put back in. And the other advantage, which is the main advantage, it's very easy to bend and unbend because it's got a nice copper tip. The old-fashioned systems were stainless steel, so once you bend and unbend, they fracture very easily. So it's easy to maneuver from one access to one root canal to another in the same tooth even. So while this is already ready to go, what I'm going to do is I've already measured the measurement to be 13 mils, so I don't want to go any more than 13. And the main reason for that is I want to be about 5 millimeters or so away from my working length. So your heat out's going to be about 5 mils short. For the very slender preps, and this is one example here, like an 04 taper or even a slimmer calcified canal where I've really minimally prepared, I like an 04 element. So the first thing I do is I heat the top portion of the GP, like so, and that's a waste. I get rid of that part. And then I would plunge into the center of this gutta perca. So I often keep it quite centered, and I plunge in. So I let that cool, and then I heat against one wall for about 1 second, let it cool. Heat against the other wall for about 1 second, let it cool. Then the third time I heat for a few seconds, I sort of wiggle and pull out the top portion of the gutta perca. And so I just wipe all that waste away, and then I move on to the smallest plugger, or maybe this plugger, which is the next size. And I go ahead and just sort of compact the GP down so that it basically, as it's being compacted, fills any lateral ramifications, isthmuses. And of course, most canals are not round, they're oval, so it's able to fit better within the confines of the root canal system. And I often would go back and I would repeat this step one more time. So that's why, I haven't got quite to the point that I wanted to with the first one. I like to do this twice. So therefore I go back in, I heat that a little bit more, wait 1 second, let it cool, wait another second, let it cool, a few seconds, and I pull out a little bit more of the gutta perca. So once I do it twice, I'm around about the 13 millimeter point which I want to be. So I just make sure I compact it very flat. The other thing is to keep that portion there as flat as possible. So you want to make sure it's nice and flat. So one of the voids you end up getting is actually at the interface between the backfill and the cold GP. So occasionally I might do it a third time, but most often twice is enough because the apical portion to mid-root portion fits the root canal system really accurately. I always use a bit of sealer at this point because you want a thin amount of sealer, but you don't want no sealer. No sealer means you won't get any bonding to the root canal walls, obviously. And then I move on to the backfill system. So the first thing I do about the backfill system is I sort of get the shape of the needle part correct, so it's able to go quite freely into the root canal system because every tooth, every area in the mouth is different. The second thing I do is I bleed the first part of the gutta perca. And what you see is this nice stringy, softened gutta perca, almost like injecting GIC, comes out of that. So I bleed the first part, I must have this right over the top of that flat gutta perca. And the good thing about this unit is it's quite fine. It's a 25 gauge at the tip, so it's quite fine. You can see the surroundings, especially if you've got magnification, which with endodontics you should have. And then I inject, and I let it inject me out. And I inject in increments of around about 1 to 2 millimeters. I go to the larger plugger, which is this plugger here, and I'm able to compact that softened gutta perca. Once again, nice tuck fit against the root canal confine. And it's able to fit into any isthmuses, lateral canals, because most of that isthmuses are in the coronal part of the root canal system. That is why I use this system. And occasionally I use more sealer. Occasionally I don't need it. And I go ahead and again do another increment. Some people inject in one attempt all the way to the top, but I like to do it in several attempts because I'm able to add sealer in between and make sure it's compacted well. And towards the top of the root canal system, if necessary, I add a little bit more sealer, or I might place a base. Sometimes I seal the top of the root canal system with a base. But for the purpose of this exercise, I'll inject another small fragment of gutta perca, and I might use the larger Buchanan plugger, and I go ahead and sort of just pack the top of the root canal system, as you can see. Might use a base over the top of this final increment of GP. So I like to just have a look at the quality of the obturation, and what I'm seeing there is no voids and a well compacted root filling, and it's a nice smooth tapered root filling. I do see a little bit of sealer puff, and the main reason for that is because I kept my cone to the working length, and I should have been around the middle short of working length, or maybe gone to the next size up cone like a 4004. And you can also see it's nice and well condensed up the top of the root canal system as well, which is what the aim is, to have no void at any interface between cold GP and warm GP, and also right through all of those increments of GP that I added. There's no void, there's just sealer and GP, quite uniform.
So hopefully that helps just sort of clarify how I do things every day in clinic when I obturate root canals, which actually is the most fun part of endodontic therapy for me, because visits where they come one after the other, where you don't have to locate canals, or it's just more smooth. I've developed a way where most of the time, by the time I get into the tooth, it takes 8 to 10 minutes until it's finished. So every case is pretty much 8 to 10 minutes. Obturation's made a lot easier these days. Some of the common problems, the things that you might encounter when you perform this treatment, and I'm hoping that this video is available so you guys get to watch it again, but it is actually, that part of the video, if you type my name, is available on YouTube as well. So you can always watch this again, parts of it. So the master cone can be removed occasionally when you heat it out, so you can sort of understand as you go in and you do what we call the separation burst. If the cone's not snug fit, doesn't have tug back, let's say, you can sometimes heat it out and start over again. In the old days, that used to happen a lot more because you didn't have perfect fit gutta perca. But these days, you've got perfect fit gutta perca, which is going to reduce the risk of you pulling out the GP and then starting over again. But also with practice, you're less likely to pull out the GP, because practice means you know how to use your element and you get your way of, heating it out and making sure the top part of the GP is separated before you pull out the whole GP. And another sort of thing that we do in very, very wide root canals, we use MTA or we use bioceramics all the way, just on their own without GP. So that's another way where if it's very irregular, the root, or very wide, we may not use conform fit, which fits better. We may go for MTA-like materials. And again, I'd already told you guys about voids, but the most common voids are coronal, or sometimes when you're injecting, it lifts away your back filler, or it might be between cold and warm, the single cone, and where you're adding, especially if you're using thin pluggers and the sharp point of the pluggers leaves a void. And so My take-home messages from this lecture: obturation is only as good as your preparation. So you want to make sure you use more minimally invasive procedures, try to preserve as much pericervical dentine. And of course, these days with match taper systems, conform fit GPs, you can keep your tapers quite small and you can fit your GP perfectly to your instrumentation system, such as the HiFlex EDM system or the HiFlex OGSF system, where your cones fit perfectly every time. You increase the gutta perca, so that's why you might, in irregular roots, use warm GP or the coronal part of the root canal system, that 3-4 millimeters below the RFI, and you want to minimize the sealer because it's the weak link. Bioceramic sealers together with single cones are the future, especially as we move on through this phase. We'll have less bioactivity, or that we make them less soluble, more stable over time. Now, finally, I want to mention another file, my favorite file when I retreat. And I say this, I know it's Coltine and Henry Schein, but it's the truth. Both myself and a number of other endodontists, such as Associate Professor Jeff Young, we love the Coltine 3007 HiFlex remover. Why we like it is because traditional retreat files, such as M2 retreats and ProTaper retreats, they were like a screw. They went straight, and a lot of times we pushed you away from using D3, which is the apical zone, because you would ledge, elbow, perforate, transport. It's able to go round bends, so you can actually pre-curve it somewhat, and it's still quite robust and strong, and it really nice and smooth removes GP. Have a look at this, courtesy of Associate Professor Jeff Young, where you're able to remove GP really efficiently and quickly, and it's not going to weaken the root or transport the root or transport any part of the root canal system. I can tell you that because I do retreats as a living. It's my bread and butter, of course. So as long as you've got it about 500, 700 RPM and use it on extracted teeth or plastic models before you go on to the real teeth, it's a very nice way to retreat. Apical zone, I often use headstrums. I like headstrums to watch wind my way in and plug the apical GP. So still apically in round the curves, even though it's the HiFlex removal, it's more flexible. I prefer to combine it with the headstrums, and that's when I might go beyond the 10 and use a 15, very occasionally a 20. Pre-curved though, I pre-curve anything above a size 8. Even a size 8 I might pre-curve as well. So that was pretty much all I had to say. I might have told you things that you already know. I might have shown you a few new things. And honestly, with me as an endodontist, being a clinician as well, I look at things carefully. I read literature. I critically analyze the literature. I look for the higher level of evidences. And, the reality is that change is the law of life. I can't keep using what I used to use in the past because no longer it'll be available. So, the technology is moving really quickly. It's good to keep up with it. And I learned a lot from the postgrads as well, the ones I teach at Sydney and Melbourne. And I learned a lot from everybody. So I've just told you how I skin a cat. I'm sorry if you're a vegetarian about this joke. But there's different ways to skin a cat. And I'm sure another endodontist will tell you a different way. But I think we need to move on and change and, take on all the new things in technology within, reason and within, okay, is it going to improve the way I do things or not? If it doesn't, then stick to the way you do it, but you'll have to change. Materials and techniques and equipment keep on changing. Even the old ones, some people don't make them anymore. So if you're interested in learning endo, I'm just giving a little plug on ADA New South Wales because I think it's one of the best teaching centres in Australia. If you don't do postgrad and if you still want to learn a bit more, come to the Advanced Contemporary Endo, not the Advanced Endo at the ADA New South Wales, Advanced Contemporary Endo, where I run the program quite successfully. It's always full a year ahead. If you want to put yourself on the wait list, put yourself on the wait list in March and August 2025, because at the moment we haven't advertised it, so it's most likely only part filled. And if you really want to learn a bit more, the only long course in Sydney I'm aware of is called the Mini Residency in Endodontics. Again, I run it, and multiple head of courses, convener of Melbourne program, convener of Queensland, Professor Ove Peters, Perth, Professor Paul Abbott, and Professor William Ha, Sydney, myself, we run a 4-modular program. It's like an 8-day program. It's module-based, and you start with basic access, and you move on all the way to retreatment and even fractured file and complex management, surgery, crown lengthening. Even we've got periodontists teaching guys hands-on. It's very hands-on. If you're interested in theory only, we still have spaces this year from July to, it finishes in May 25. But if you want the practical, you've got to wait till, the July 25 to 26 and put yourself on the wait list. As a long wait list. Or if you want to learn and you can't get into long courses in Australia, go to King's College of London. They run a pretty good program. There's a program in Italy. There's a program in Canada, North America. So look for other programs overseas. But why we run it in Sydney is to save you guys the hassle of staying away from your practice. And whoever goes through the program this year, we just did the interview last week for Sydney Uni. 2 out of the 3 that got in actually did this program. So it does have value, and I'm sure others that apply to other states, if they say they've done long courses, it's more important doing primaries. Any questions, Joe? So I'll just stop sharing. But thank you, Joe, again for inviting me, Colteen, Henry Shine, everybody who's created this platform. Great platform, and I think really good turnout by what I saw.
Thanks, Mehdi. What a fantastic presentation. Really thorough. And we just got 2 questions that's just come in. I guess the first one is single cone technique you mentioned with OGSF, for example, minimal invasive preparation, which you're starting to incorporate a lot more into your daily routine with endo cases, and the gutter flow bioseal. I guess the problem of voids, are you finding any issues with voids, or is that all manageable? Like, you're not finding any issues?
Yeah, so basically, as I said, because you machine the root canal system, there won't be any apical mid-root voids. Most of the voids are coronal, and that's to do with the operator, like just practice. And because the reality is that the papers, such as Motamedi and William Haas paper, and the Iglesias paper, as I alluded to earlier, are telling us when you do single cone, most of the voids are coronal. Therefore, this is why you combine it with warm vertical, so you're able to inject warm GP over your cold GP, which is fitting perfectly to the confine of the root canal system, because there's less ovoid shape root canal as you go, or ribbon shape, less isthmus as you go middle to apical zone. That means that your GP fits perfectly, there's no voids, and then coronally, as long as you do your backfill over your GP correctly, as I showed you in the video, then hardly ever you have any voids anymore. And I recommend, because you practice this, you take an extra radiograph just before you put your base or core. Take a radiograph to see how well you've done it, because you can always heat out and add a bit more. Most of the voids are coronal when you do single cone, according to the literature.
Thanks for that, Mehdi. Makes sense. The other question was HyFlex remover in retreatment. Can that also be used for gutter core and thermophil?
So yes, and not thermophil, because thermophil has a hard carrier. But if we're talking gutter core, soft core, gutter fusion, which are alpha and beta phase combinations of gutter perca, of course you can. Of course you can. So you can use it. And as I said to you guys, bioceramics and MTA-like sealers, it doesn't mean you cannot retreat them. They are retreatable and retrievable, because sometimes you've got to retreat. Occasionally, I tell you where I might retreat, my own cases. I went very conservative, and let's say a number of years later, I realized there's a lesion. There might have been a mid-mesial that I didn't trough enough for. There might be a situation where I need to go to a larger apical size. I always went conservative because I know the number one reason for failure is fracture. I can always go retreat it. So I will have to retreat my cases. You will have to too. And if you love your endo, you'll be doing it yourself. If you're an expert dentist or you don't have an endodontist around you, I'd rather you save the tooth. That's why I teach all these courses. People bag me out every single time. I teach too much. They say that to me. The reality is I'd rather teach you so you preserve the tooth, because nothing will ever replace your natural tooth. Even in the compromised tooth case, there's literature to suggest there's still a good reason for the right patient. Again, patient-centered approach. You want to save the tooth. Therefore, there's nothing wrong with retreating And if you're going to retreat it, you make sure you use the right equipment. That's why the HyFlex remover and coming to courses will help you retreat in areas where a patient can't afford it these days. They can't see an endodontist. You can at least retreat the easy cases or the cases where you carefully assessed, and we've taught you that you can retreat. No problem with gutter core at all. You can retreat a gutter core. Thermofill, different story. I don't recommend you guys retreating thermofill. I think you should refer that.
Awesome. Thanks, Mehdi. We've got no other questions, so I'd like to once again say thank you, Mehdi, for an awesome presentation. Thank you, everybody, for attending and listening and joining us tonight. And with that, I'd like to end the webinar. So thank you very much, everybody. Enjoy your evening. And just before I do that, just for those who want to know a little bit more, get more information, Colteen is running a endodontics workflow made easy. I'll just try and bring that up so you can see. That's going to be on the 26th of July this year. It's a full-day program with Dr. Bobby Battelle and Dr. Charlene Desai here in New South Wales. And you can go on to the Dental Education Hub website to get more information. And with that,
it's been an absolute pleasure. But if there's any other questions, you can always email me, mehdi@gentalendontics.com.au. Happy to answer in the future. Thank you.
Thanks, Mehdi. And thank you, everybody. Have a great evening.